Well, good evening, everyone. I'm Paul Sorajja from Minneapolis, and I have the pleasure of kicking off the latest edition of Nail It with Nadira. This is a webinar hosted by a CVI Foundation, and tonight's topic is on CIED Related TR with perspectives from our EP colleagues. As I mentioned, Nadira and I will be leading the session. I'll be turning it over to her momentarily, and we have the pleasure of doing this from Minneapolis. We're joined tonight by a number of esteemed colleagues, Dr. Devi Nair, Dr. Robert Schaller, Dr. Roderick Tung, and Dr. Firas Zahr. This will be a wonderful discussion about an incredible problem I think a lot of us are seeing in terms of how to treat TR in the context of CIED leads. I hope many of you will be joining us this year in Austin for our annual meeting. This will be our 8th installment of CVI, the Operators Enclave. This year we'll be at the JW Marriott in Austin, Texas on July 24th to 26th. Each year we have about 1,200 attendees that come for a case-based discussion, and I hope to see you all there. If you'd like to follow us, we're active on social media, including Twitter, Instagram, Facebook, and the like. And for any archive materials related to this webinar or similar webinars, please visit our website, cvinnovations.org. And so with that, I'll turn it over to our host for tonight, Dr. Nadira Hamid. Nadira?
Thank you very much, Paul. Let me share my slides. Can you see my slides?
Yes.
Perfect. So once again, thank you so much, everyone, for joining us in today's episode, the first in 2025 of Nail It with Nadira with a CIED related TR. And from an EP perspective. And today, as Paul mentioned, that we are joined not only by the KOL in the structural world, Dr. Zahr, but also KOLs from the EP world, 3 of them who will be talking to us interesting cases on CIED related TR and from an EP perspective, what we cardiologists have to look out for. And finally, an update on leadless pacemakers by Dr. Nair. And so before we touch on the previous webinar that we talked about on how to perform a tri-clip in CIED related TR, we went through multiple cases, interesting cases of how to tackle it. And these are the 6 proposed mechanisms which I've discussed on the previous webinar as highlighted by the heart valve collaboratory paper. In regards to that, this article also highlighted in terms of what are the candidates for transcatheter tricuspid valve devices besides the repair, which we discussed in the previous webinar, in terms of replacement. What are the considerations after placing this TTVR devices in CIED-related TR, and the assessment of these leads, of jailing these leads, and what are the follow-up of these patients. And so without further ado, we'd like to introduce to you Dr. Zahr, who will be taking us through a very interesting first two cases. And so, Dr. Zahr?
Thank you so much, Nadira. Thank you, Paul. Thank you for CVI for hosting this really cool event. And I did not realize that I might be the only interventional cardiologist who's speaking. And with that being said, I will admit that I will be and will sound as the dumbest, and that is all right. And but let me just tell you 2 cases that I would like to review with him. Both are done with a commercial evoke, and this is exactly how I feel when it comes to TR and lead. I'm either too early or too late, and never on time. And it's always tricky. And I'll tell you why. Next, please, Nadira. So this is the first one. 83-year-old 6 sinus syndrome, dual pacemaker for 6 sinus syndrome in 2020. So about 4 or 5 years ago. Echo in 2019, normal RV size and function, trace TR. Echo in 2020, mild increase in RV size, moderate TR. This is after her pacemaker. And then 4 years later, she was having severe TR, as you'll see. The first hospitalization for heart failure was in 2021 and she was noticed to have severe TR. I'll go next. And this is her echo, and I thank you. It is hard to see, but you can see severe TR. And again, I'm an interventional cardiologist, so severe massive interventional are beyond my pay scale. But I call them pretty bad TR, and I think that this is pretty bad TR. And you can see that there is a lead impinging on the leaflet. Next, please. And this is the TEE. and severe TR and septal lead impingement with the lead. Go next, please. So, and this is the transgastric view. My imager, Scott Sheridan, thought it was torrential, and he thought it was mainly with the lead is anteriorly, but it extends all the way posteriorly. And my experience with those, the lead might be responsible for the first insult, but then the disease progress and it becomes functional, TR. And sometimes it's hard to tell which one is first, the chicken or the egg. I thought, given the history and the fact that she didn't have any TR before, that the lead is probably responsible. Next, please. And this is the lead. And we X-ray every lead, and we do it on the CT. And next, please. And we thought in this case, we will treat it with Evoke. And we put a safari wire and the Evoke crossing, and we try to be, very vigilant in where we put the capsule of the device in relationship to the lead. Next, and it felt that the lead wanted to be anterior, so we respected that, and we let the lead go anterior. The device went posterior to the lead, and you'll see there's enough slack on the lead, and therefore we thought that the lead will be okay. Next, please. Deploy the valve. This is the valve, pushing the lead septally and anteriorly as the lead wanting to be. And you'll see with MPR, beautiful images by, Scott Chatterton, showing that, the lead is captured by between the anchors of the Evoke. And go next. And there was a trace a PVL, and the results were amazing. This is the final result. And the device is jailed exactly where we wanted the device to jail the lead. Next, please. And the final result, as I said, there's a little trace perivalvular leak where the lead was, but nothing significant. And we always interrogate every lead that we jail with the TTVR. And if you don't mind, maybe I'll go next. We look at the thresholds. We look at the capture. The day of the procedure, the day before discharge, and follow-up. So now this patient has 2 years follow-up, and the lead is doing okay. However, I still to date wonder, should the lead have been removed? The patient is requiring minimal pacing. She was not pacer dependent. The lead was relatively new. It was within 5 years. In this case, we decided not to expose her. She's older. We decided not to expose her to another procedure, and we decided to jail the lead. And up to 2 years, there's no consequences. With that, I'll move to the next case, and I'll leave it up to you if you want a discussion now or after the second case. There will be advantages and disadvantages of both. So I'll lean on you.
Thanks, Firas. Paul, I think we should, probably discuss this case first. What do you think?
Yeah, I think it's probably a good idea to discuss this case. It's really interesting how certainly this is a patient who we try to offer a transcatheter solution based on their age and such. I would love to hear from our colleagues in EP a few things. We often have a discussion about lead extraction versus jailing. Can you help us understand some of the risk factors that are related to injury to the lead that would increase the risk of lead fracture that we would have concerns about jailing? I think a lot of us would rather just jail rather than extract because these patients tend to be elderly and the risk of extraction can be what they are. Of course, if we could extract, that would be easier, but a lot of times we're left with the choice of jailing. So could you help us understand that? Maybe Devi, do you want to start?
Yeah, I think the way I look at this case, you have to do what's right by the patient at your center. But for a 2-year-old lead with the RV pacing percent that's so low, I would feel very comfortable taking that lead out, and seeing the tricuspid valve after. You might still need to do TTVR. That's a different story, but I would feel very comfortable taking that lead out. I think the risk of removing a 2-year-old lead, and when I look at that CT, I don't see a lot of calcium and
It's
things.
5, Debbie. It's 5.
5-year-old. Okay.
Yeah. So it's
Okay.
still not decades. So it's 5.
5 years. Okay. I mean, even with that, I think I know we talk about risk of lead extractions being high, but I don't think with the current tools that we have, it's not that high anymore. At least that's how I feel about it. I also am a very huge advocate of leadless therapy. So I feel like you could take a transvenous lead out and give the patient leadless implant, especially with a lot of options available now. I think that's not a bad idea again, but you have to have an extractor available in your center, right? So it's really center dependent and how collaborative your team is as well.
Well, Debbie, you clearly are an expert. What would you quote a risk for extraction in a patient like this? And does it vary according to the type of lead?
I mean, it's a pacing lead. I mean, I would say the risk of injury is, I mean, I coded under 2% for this case for any kind of tear or anything of that sort. Now, the lead extraction alone could cause the TR to get worse. That's possible too. I could injure the tricuspid valve more. But I also don't like the idea of a jailed lead because I worry this patient, is going to have if they have an infection or something like that, now I'm in serious trouble of how am I going to take this lead out? Now I got real problems.
Rod, how many centers in the country would have that type of experience? Could you estimate for us in terms of lead extraction? I mean, we have to, as we think about tricuspid therapies for replacement and repair, there are hundreds of centers that are going to be doing replacement and repair. But how many centers are there in the United States who are doing extraction in your best estimate, could you say, with outcomes like Debbie's?
Yeah, why don't we go to Schaller, because Schaller is really the extractionist extraordinaire, and then I can comment on that.
Okay.
Thank you, Rod. I don't know, not too few. I don't know about hundreds, but 100 at least. These are complicated questions and situations. The decision to remove a lead before TTVR has to do with the lead and patient characteristics, how old the patient are, how old the lead is, and what the patient's pacing needs are. And so 83 5-year-old lead, the risk of that procedure approaches 0. The risk of anesthesia is probably higher than the risk of the lead extraction. And we have plenty of alternative modalities to utilize with her, whether she needs a device at all. The second question is, does she need, what happens if this lead fractures, or more likely the insulation breaks when it's jailed? And if she was dependent, that would be a real problem because it's really not really known how often these leads are breaking in time. So that would be another clue that she should have an extraction. But the bigger implication is what Devi said. If you have, no matter how old the lead is, the moment you jail it, you can't remove it ever again with our tools. So you're setting that patient up for the need for open heart surgery if she needs the leads out, or some other unappealing solution like lifelong antibiotics. So that's the implication, and it's a theoretical one, but it's not a great outcome if you could avoid it. So what we do, and what I think every hospital should do, whether in their hospital or through a referral network, is set up a heart team so that you can discuss the pros and cons with a local lead management expert. And that way you can decide, because if this lead was 31 years old, you should jail it. But if this lead is 1 year old, it would be a sin to jail it. And everything in between is a discussion.
Okay, how about this? Maybe I asked the question the wrong way. Who would you not extract?
Well, again, if someone has 3 31-year-old leads,
Okay.
there's no way you would extract that. The other variables are they dependent? If they're not dependent, there's less skin in the game in terms of pacing. If they have a very, very low risk of infection in the future, there's less risk. But if they have a high risk of infection in the future and they've had endocarditis in the past or something like that, there's a pretty high chance that they're going to need those leads out. And just to be very clear, we just can't use our tools predictably when the lead is jailed. So 99% of centers would never, ever attempt to remove a lead that is jailed. Now, there are going to be some centers, ours included, that will probably give it a go, sometimes because it'll be the lesser of two evils. But those are going to be unpredictable and unfun procedures. So you have to think about what the risk of that is down the line and go from there. So if a patient's 98, probably jail.
Okay. Nadira, probably should move on to, go ahead, Rod. Yeah.
Well, I just wanted to also reflect. I don't think you're going to find many electrophysiologists that would say jail this. And particularly in the pacing burden being so low, that's a chip shot for us. I think 99 out of 100 electrophysiologists would say, let's extract this. And I agree. We're all very concerned about what's going to happen with endocarditis and how to remove it. The other thing that is glaringly obvious, but not obvious because we're so downstream in talking about this is it is ironic that the cases that I've seen that are worse, anecdotal, are the ones that don't even need an RV pacing lead. And that just speaks to prevention and non-maleficence, that this is a patient with sick sinus syndrome, and we should be European on this type of stuff and not implant in the beginning. And there's a really great CERC paper from the late 90s that randomized over 200 some patients with intact AV conduction. For us, we didn't see an EKG on this presentation, but the point is that if you've got normal PR and people pace fine at 100 to 120, the risk of developing heart block with sick sinus syndrome is 0.6% per year. It is so low, and the fact that in America we implant duals in all of these, it needs to be reevaluated.
Fair enough. All right, Nadira, we probably should move to the next case.
Yeah, Firas.
Love this.
So I want to be clear. My task was to show two cases that we jailed lead with Evoke. And I'm going to stick to my task. And I'm trying not to give an opinion about jailing the lead or not jailing the lead. But I would say in our program we do exactly what you guys suggested. And but I would say that we involve EP in every single lead that that we get involved, and we try to extract every lead. And I'm trying to build a case that it's not only for the lead, but it's also for the TTVR. I showed a case that jailing the lead, the lead was there, probably that was used less than 5% of the time. Probably the patient didn't need the lead. The lead was jailed, and if the patient had endocarditis, she was 80 some years old and she had endocarditis, the lead will come out with the valve. But the lead also have an implication on the procedure. And this is a case that is an 82-year-old female, AFib. She had AV neural ablation. She's a pacemaker dependent, dual chamber pacemaker. She has sternotomy for an MVR. She has CKD. Her STS is 10. She had torrential TR, probably lead induced. She's on a hefty dose of diuretic, and her lead was put in 2016. So at this point, it's almost 2006, and at this point, it's almost 20 years old. So go next, and this is her TR. Torrential, massive, whatever you want to call it. The lead is impinging on the septal leaflet, and go next. And this is the lead, and I think that one thing that we focus on is how much slack is in the lead. And unlike the first case, so the first case we had the conversation, she was 80 years old, she did want an additional procedure. EP was like, yeah, if you jail the lead, if it goes bad, it goes bad. She's not using it anymore, and she doesn't want the lead out, and it's probably okay. To your point that she probably didn't need it in the first place. This one is different. She absolutely needs the lead, but it is 30 years old. So we looked at it for 2-tier, huge gap, leaflet impingement, and it's just not a good option. TTVR, we mean jailing the lead. The risk of taking out the lead, we thought it was too high. Medical therapy, she's on humongous dose of Lasix. And, as I said, the lead, the risk of removing the lead at 20 years in an 83 years old with an SDS of 10 thought to be very high. Go next, please. So this is we sized it for Evoke. We thought it was a 52 millimeter Evoke. And go next. And this is the procedure. So we go with the procedure. We get the Evoke valve across, and we thought that the lead is want to be anterior, and we wanted to respect that. But then, as go next, as we just once we we were very deep with the valve, and go next, please. Once we open the anchor, we quickly interact with the lead, and we were entangled deep in the ventricle. Push the wire, we try to snare the valve, we try to balloon, we try to move the lead. I mean, we try all sort of different procedure. The the lead become like a track that the Evoke is just going to slide up and down on that lead. Go next. And we could not unentangle the valve, from the from the lead. We tried to pull it, we tried to push it, we tried to do all sort of gymnastic maneuvers. And go next. And you see the lead is rotated with the with the tracks of the Evoke, and the lead has no slack in it. So I think this is the key that we learned in this case, is that if you have no slack in the lead, it's very hard to mobilize the lead freely. And go next. And we try to pull the whole delivery system, push the whole delivery system. You'll see a big PVL, where the leak is, where the lead is, and it's like wide open, and the valve is like canted sideways. And so at this point we were do we open the chest, or what do? We push the delivery system aggressively, and we were able to have the valve torque the lead. And I'm pretty sure many of my electrophysiology colleagues on the call are having chest pain as they're seeing those films. I can promise you that I was having chest pain as well. Chuck was behind my back, and it's like, well, I'm not sure what you got yourself into. We're not sure what to do at this point, and go next. But luckily, we were able to use the force of the delivery system to cant the lead and cant the valve around the lead, and we were able to achieve very good results. Mild PVL if you go next, and we might have damaged the leaflet of the valve as we try to push it with the delivery system. So in follow-up, the patient's doing well. However, syncopal events, and we after all of the pushing and the pulling on the lead, we interrogated the lead, and it was malfunctioning. The patient was admitted for emergent leadless pacemaker implantation. So she's still doing well, but I think I learned quite a bit in this case. That to your point, Robert, about how do you manage the lead, look at the lead and look at the patient, is how we manage TTVR, look at the lead, look at the patient, and have an open dialogue with electrophysiology. So this lead is jailed, and it was damaged by the TTVR, and the patient got a leadless pacemaker. So
can I ask you a real quick question?
Please.
At MA, you have to do what you have to do, and I completely respect your gymnastics. But at what point, like I was asking Rob and Rod, like what point would you consider a CS lead before even considering TTVR in this instead of a leadless? Is what I'm just wondering, at what point do you guys as interventionalists think about coming in for a dependent patient for us to put a CS lead away from all of the valve?
Yeah, so this is a very good question, Debbie. I mean, what you're asking is, like, do we, you have to understand that a lot of those TTVR is young. Like we're learning how to do this, and how to do it with lead, and how to do it without lead, and which lead can take it, which patient can. We're learning patients. We're not even learning, how to manage anatomical challenges. But in this case, for example, what we are learning is which leads we're more likely to damage. And I think that, looking at the slack, looking at the trajectory of the lead, looking at what type of lead, and, having the conversation, about it. Like, for example, if it's not necessarily that every lead that we jail is going to malfunction. And, so it's hard to say, well, proactively, we're just going to put CS because we're guaranteeing that we're going to damage the, the RV lead. We have adopted a strategy and see what happened. I feel like putting a CS lead to give you an extra cushion, but it doesn't give you justification to blindly jail the RV lead, because, it's not only you're damaging the lead, but also, the procedure will be complicated, the TTVR procedure.
Thank you, Firas, for those two great cases. I mean, really the key learning points, I think this is your slide. When I was doing up this slide for you, really respecting the lead. I think that is the key thing when we are thinking of replacement technology, right? For us, the points that you brought up in terms of the AV block, the inducible RV lead changes with a replacement technology. And for us, interventionists and imagers on, when we are looking at assessing patients for replacement technology, there's so many factors just besides the annular sizing, the lead slack analysis, the procedural attention. Me as an imager looking at the TEE really aggressively and the CT imaging as well, in terms of planning procedure-wise. And, like, Paul, please chime in terms of if you want to move the lead as well. I think we've done it in several replacement technologies, where we move the lead with Oscar or Gillis. And also the lead extraction. And I think this will set a pace to the next case by Bob Schaller, in terms of, what are the things to consider in terms of lead extraction to look out for. So Bob, here you go.
Okay, thank you. So we've been getting more and more referrals, like many centers have, to remove leads for severe tricuspid regurgitation, and more recently to get leads out of the way. And it's interesting. It's creating a lot of new scenarios and experiences, and we're learning quite a bit. So here's a case that we just did a month or two ago. It's a 37-year-old woman who had vasovagal syncope many years ago, and a single chamber pacemaker was placed in 2002, and she actually did quite nicely after that. Sometimes these patients do well with pacemakers, sometimes they're not needed. But she was diagnosed with progressive CIED TR. So you can see the echoes through the years increase. So I think Firas is right. I think this was an initial insult, and then it just kept getting worse through the years. But you can see that she's starting to dilate a little bit. Her annulus is bigger, her hepatic vein flow is reversed, and her RV size is normal, but she has severe TR. She was referred for extraction because she was so young, although she wasn't really symptomatic yet, and her height was 5'2". And the reason I say that is because a lot of times when patients get pacemakers when they're very young, they think that they're going to grow. This patient maybe was already fully grown, but the congenital population has these big loops frequently in their pacemaker leads in the ventricle or in the tricuspid valve, and they're very annoying. So I've kind of drawn where this lead goes. The lateral tells the story, of course, with a loop going right through the tricuspid valve. This is a terrible thing to see. In lead extraction, we have really mitigated the risk of almost every single complication, including SPC injury, to very, very, very low numbers. The one complication that I do worry about still to this day is tricuspid valve injury, because sometimes that's not in your control. The lead is attached or even through the valve. So this is a tough case. So the question is, do you just send this patient for surgery? That way they could remove the lead very easily, replace it with a ring, and she'd be good to go. But that dedicates her to surgery. Do you take it out percutaneously? It's already a difficult case. This is already a 23-year-old lead in a very young person that scars. And if you get it out, fantastic. She might not need surgery. She still might. But if you damage the valve while you're doing it, then not only will she need surgery, but she might need a tricuspid valve replacement, which would be bad. or it will no longer render her a candidate to be to receive a TTVR. So the consequences are serious. So this is our TEE. You can see that the loop is below the leaflets with severe TR. And you can see the loop and the leads are restricting almost all of certainly the septal and the posterior leaflets, but it looks like it's restricting all of the leaflets. It's just caught up in so much stuff. And here is the color Doppler. So in our lab, we don't use TE during lead extraction. We use intracardiac echo because we use that in almost every EP procedure. So it makes more sense to do that during lead extraction. It's also a better modality for lead extraction, but that's a different talk. So with AP fluoroscopy, you can see that the loop is right there in the valve. With intracardiac echo, and we actually use a mirror image of this ISO. This actually is unusual for me, but I tried to flip it for the audience. You can see the lead coming down, and then the loop is coming up and around the subvalvular apparatus and touching the leaflets. Whenever you see brightness and lead extraction near leads and valves, never a good sign. It means there's probably some calcium fibrosis there, and it just looks terrible. You don't know what you're going to find or what's going to happen to the apparatus when you start pulling on it. So we use a telescoping laser system in our lab, and it works really, really well to remove leads, but you have to pull quite a bit on the lead to form a rail, almost more than you push with the laser. So when you're advancing with the laser, you're also pulling. And the moment we started pulling, you can see that the loop starts to unravel just a little bit. And ICE shows us that it's not only attached, but it's densely attached to one of the leaflets, probably the septal leaflet of the tricuspid valve. And you can see all the fibrosis and calcium that's here. So this is what I call a vulnerable valve. And it's this stuff, it's like nightmare fuel. You hate seeing it because when you see this, there's a real chance that you're going to damage that valve, even if you use the right techniques. And we're not even sure what the right techniques are, but we think the best way is just to laze through all of that stuff to try to core it out. So that's a bad sign. As we progress our laser even further, you can see that we're pulling even harder. Here's the tip of the lead pulling on the inferior wall. This lead wasn't very apical. Another probably bad thing to do is keep these leads very basal. So you're pulling on the inferior portion of the RV, and you're also pulling on the tricuspid valve leaflet as we make the turn around the SVC. Again, we really want to pull hard because we don't want the sheath to disrupt any SVC tissue, but we don't want to pull too hard. So this is probably the limit of what you can pull without jeopardizing that leaflet. So we're having a hard time getting down now. We can see that the TR sometimes gets worse when you're pulling like that and you're pulling a leaflet off. So we can't progress. So we don't like to laze too much on the SVC to reduce the risk of SVC injury. So we really just want to push these sheaths down, and we just can't get down. These leads get thick over time because there's adhesions on them, and it's hard to core them out. So rather than pulling harder or using more force, what we'd like to do is get a bigger sheath. So the loop has already come out, but we just have this focal adhesion. So we get a bigger sheath. This is a 16 French sheath. And this one allows us to get down a little bit further with the telescoping system. And then what you want to do in this situation is you laze a lot up here. You don't laze much here. And then you laze a ton through the valve. And I think that's the best way to avoid an injury. So here you can see that's what lasing looks like with intracardiac echo. So we're lasing right through all of this junk. Does not mean that there won't be an injury, but there probably won't be an injury. And we get, this is the biggest laser we have. So we try to get that all the way to the tip. And eventually it's so thick down there that the laser won't even progress. And we have to just use the outer sheath here and get it all the way down to the lead tip and then pluck it off. And then once it comes off, you quickly look at your ICE imaging and hope that nothing bad occurred. Usually you can tell if you've disrupted something when the sheath already passes through the valve, but sometimes you can't. And so you look real quickly afterwards and see. Here we see there's no damage to the valve, but you can see all the cast, or some people call them ghosts, or where these leads where the leads were. Not sure if this is one here, but frequently there's a lot of junk underneath the in the subvalvular apparatus, casts, ghosts, and just scar tissue, sometimes waving around a little bit. We couldn't care less as long as there's no flail leaflet or a avulsed papillary muscle. So the TR remains severe. And we placed a leadless pacemaker. Some patients with vasovagal syncope really don't need this. You got to rethink it. But in her, we chose to do it. And I think good thing we did, because 2 hours after in the PACU, she had a profound vasovagal episode. She was pale as a ghost, and she paced for minutes on end. So I do think it saved her from passing out. And the implications of putting in a 20-year, a leadless pacemaker that lasts for 20 years is not that great. So we had a repeat in 3 months, and I'd like to give everyone watching 5 seconds to think about what they think happened. Did the TR get better or did it not? And if anyone wants to guess, now's the time.
I'd be really surprised if it got any better. I think
we had a series of 33 patients with extraction, and 1/3 of them got better. So
yeah,
it's possible.
No difference whatsoever. So the panelists had some experience here. We have also put together our recent data, and it's very rare for patients to get better, especially when their annulus is dilated. So no improvement whatsoever in TR, and this is really the typical result. So the more important fact is we cleaned out that valve, and if she needs, and we did so safely, so she could have a TTVR, she could have a ring placed. If this doesn't get it better, but there's no rush. She's not symptomatic. We can wait on this too. And if it goes down to moderate, that would mean the world to her. So to summarize, or the learning points are about 20-25% of patients develop increased TR after leads are placed. So I really think it's important to get an echo within 1 year afterwards, because if the lead is causing severe TR, that's fixable if you just remove the lead. If it's causing a little bit of TR and that progresses over 20 years, what are you going to do? But to catch those few patients that have severe TR because of lead impingement, or if it's through the leaflet, that's important. TLE is curative only if caught quickly, probably right around 2 years. If you could remove a lead that's truly restricting one of the leaflets, usually the septal leaflet, under 2 years, you have a really good chance of making that patient better. But once that annulus dilates, the cat is probably out the bag. And if chronic, TLA may cause harm. Here's an example of a patient who had a horrible flail leaflet after the procedure. So this is a disaster. This patient needs surgery and probably needs a valve replacement. And not only that, they're no longer a candidate for the current iterations of TTVR. So a lot of thought has to go into these cases and what the possible outcomes might be. Thank you.
Thank you very much, Bob. That's a great case. I mean, one question I have is her RV function. I know we talk a lot about the TR, and one thing that I worry about, leaving them with the significant TR and their RV function, and if it affects it, what happens then? So would you do a cardiac MRI in these patients after the leadless pacemaker just to have a better idea? Or when would you intervene? Would it be only when it's symptomatic?
Are you talking about a pacing-induced myopathy of sorts, or
For this patient, this case of yours?
Well, this patient, she really had no symptoms, but at 30, and I'm not an echocardiographer or even a general cardiologist really, but at 36 with severe TR, I think it's reasonable to think about removing it.
Yeah, absolutely. And I like your point. The key learning point is really we have to monitor these patients after implantation. And like you mentioned about doing transthoracic. And I think our research fellow, right, Paul, was doing a case series of the progression of TR after lead in our center. Paul, do you want to say a little bit about that?
I think that data is still being collected, so I don't have the results of it, but it's prospectively, it's not being done enough. Because I love your point of looking out for it and acting on it while you can. because unfortunately what happens to most of these patients when they get implanted is you cure them and they feel great, and it's about 5 to 7 years when they come back to see us for their tricuspid. And by then, to our discussion earlier, it's becomes a little bit more difficult when they're 7 years older. They may be almost 90, you know, then there's the risk of the extraction that becomes a little bit more challenging to discuss. And so I really love that idea of prospectively getting an echo within the year and acting on it by then. I honestly don't think we're very good at that, and I wish we were.
That's right.
Can I
Any,
ask a question real quick?
Yeah.
Anyone of you, Rob or Paul, is there a specific characteristics on these leads that, you know, I'm yet to see one that has gotten better, a TR that has gotten better. Maybe I've just not done enough for TR. Is there any specific characteristics that you see and you're like, okay, this one is going to get better if I take this lead out?
In our series, it was ones that were central anterior septal. So not in the commissures, and not central that wasn't associated with impingement. So it's one of those, in my opinion, very limited series, Devi. I mean, I'm talking 33 patients. That's a very limited experience. But the ones that tended to get better were the ones that had just enough impingement, but not so much that you would risk injuring the valve taking it out. And it was interesting because I had sent those 33 for extraction, with the goal of either TriClip or TTVR afterwards. And to my surprise, 1/3 of them didn't need my help when after I'd sent them. So it happens. Yeah. I don't know, Bob, you have any other thoughts on that?
Well, you do also have to think about pacing myopathies in these patients. Sometimes they can be subacute on the left side, and they can definitely worsen TR. So if they're pacing dependent, like Firas's last patient, I probably would have put a CS lead in that patient. One, to avoid the lead malfunction, and two, to give it a couple of months to see if the TR gets better. That also gives you 2 months to make sure that patient doesn't have a pocket infection, which would be terrible to address after the TTVR. And it's important to note that, and this kind of is what Rod is an expert in, amongst other things, is the days of pacing myopathy are probably behind us at this point, because everyone is getting a conduction system pacing lead. So to take that off the table in the future will be helpful to make these decisions.
I love that, especially because, you know, we know we've been talking about replacement, but for instance, we know our repair results are far better when the HFpEF has been addressed. If we leave HFpEF on and alone, or a heart that's dysynchronous, our TriClip or Pascal results for the tricuspid are not going to be as good. And these patients come back. So we should be more aggressive about conduction system pacing as well as CS leads, in my opinion. So, yeah.
any
Paul,
final?
can I just comment on something?
Yes, for us.
I mean, this conversation is amazing, and I'm sorry I busted my camera, but the main thing for me is, and we see it all around. I mean, we are at the stage of awareness. I mean, you go around and you talk to different people, and it's shocking how little we know. There is little awareness about leads causing TR, like in the community. Not everybody is looking at it. I mean, the point of, if we catch it within a year, this is the golden time. That is a very good point. I mean, I think many people do not know that. I think the management of the lead and the TR is complicated, and it has to be managed with eyes on a patient, eyes on a lead, and eyes on the tricuspid valve. And there's a perception, and this is why I presented 2 contradicting cases today. There's a perception that we know what leads is okay to jail and what leads is not okay to jail. In reality, we do not know. Every case is different. And same with the extraction. I mean, some or TR respond and some don't respond. And I think that this is just a wake-up moment for all of us to try to understand how to better manage patients with leads TR, whether they're both together or one is causing the other.
Well, can I just ask, so if it's 20% of patients who have TR that should probably be addressed with extraction, that's a lot of patients to extract. I mean, do we have enough EP people who can do that extraction in the United States? I just wonder who's going to be extracting all these people.
Oh, I don't think the 20% represents the patients who have increased their TR by 1 grade.
Yeah.
So it's going to be a small percentage of those patients that are going to go on to severe
Okay.
TR. So no, that you should watch those patients, but you're really looking for the patient that went from mild to severe with an impingement. That's the patient you want to catch.
How often do you think that happens?
A handful, a couple a year.
Okay. Okay.
All right. And great discussion. And we'll, bring it home with Dr. Nair, Devi, for your last updates on the leadless pacemaker.
Thank you, Nadira, and thanks, Paul, for having us on CVI. This is really wonderful to be here collaborating with you on this very important topic. And I'll try to kind of complete this discussion with giving an update on where we are with leadless pacing and what our current trends are and what the future is for leadless pacing for us. These are a little bit on the clinical trial updates on what commercial devices we have available, what we are able to do with them, and what next generation devices and trials are upcoming. So we talked a lot today about what our considerations are when it comes to transvenous devices, whether it's complications from the transvenous device, it's got to do with the valve or with the pocket, vascular issues, anatomical issues, a patient that has very infrequent pacing, like that was shown today, a young patient, or basically a patient preference, right? Sometimes we run into these kind of issues all the time with twiddlers. I have to say the one on the left was the easiest extraction I ever did. It was one and said and done. But these are things that happen, whether it's pneumothorax or hematoma. These are all concerns that we have as we implant transvenous devices. Erosion is an issue, especially in very thin patients. Infection, whether it's pocket infection or endocarditis. These are things that we constantly deal with transvenous devices. And when we look at where does the clinical need for leadless pacing comes in, if you look at complication rates, I don't think most EPs, quote these kind of complication rates for when we put in a transvenous device. I mean, you look at the registries, it's, for lead-related complications are as high as 5%. Pocket-related is about 5%, small risk of pneumothorax. Infection risk is about 0.8 to 1%. And this is, again, another a registry that looked at about 72,000 patients with transvenous leads. And you can see, the complication rates in a 1-year period is about 7 to 9% with a single or dual. And when you look at these patients at a 3-year event rate, it's as high as 15 to 16%. And I truly don't think that even I don't quote that kind of numbers to my patients and feel like we don't do justice when we actually talk about risk benefits sometimes. And that's where I think the leadless advantage comes in, is that whole 12.4% risk of complications, whether it's attributed to leads or pocket, that we're taking away. We're giving the patient a whole new experience with no chest scar or no visible note that there is a device. There's no restrictions in arm movement. There's no concern for pocket-related complications or lead-related complications when we think about leadless devices. And if you look at the timeline of leadless devices, it started as early as 2013 with nanostim device. And, in 2016 is when we actually had the first commercial FDA-approved device, which was the Micro VR, which was a single-chamber ventricular device. Then we had the iteration called the Micro AV. And I'll talk a little bit about these devices for y'all to understand what the differences are. Then we had more recently in 2022, the VR system, which was another platform. And then the second iteration of the micro systems with higher improved longevity, which is the VR2 and AV2. And more recently, the dual chamber leadless system by Abbott, which is the VR-DR system. So a little bit on the AV2 and the VR2, which is the current iteration of the micro systems. They're both RV systems. It's a time-based a leadless pacemaker, so 4 times that kind of hold the device in place. You can see the battery longevities that we're looking at with the second iteration, and that was one of the advantages with the second iteration is a better battery longevity. Most MRI compatible system. We can do home monitoring, capture management. These are all things that we can do. Very small device from a volume standpoint, and because it's not as long of a device, we can put it in the basal area of the septum if we need to. But again, remember, it's a single chamber device. The VR system is VVI, so usually for patients who just need RV pacing, and the AV system for patients who need VDD pacing where they need AV synchrony. And there's quite a bit of clinical evidence, whether it's from the IDE trial, the registry, and also the clinical evidence development platform that showed us that there's quite a bit of lower complication rates, 48% fewer complications with micro compared to traditional historic transvenous pacemakers. Now, this was not a randomized trial. This was just comparing to transvenous data with good electrical parameters long-term, whether we looked at thresholds or sensing or impedance. Again, in the registry as well, in real world, we saw the same kind of implications, 63% fewer major complications with leadless devices. But there was something that came out is, these patients might have a little bit higher risk for perforation and effusion, especially if they had more than one risk factors. And what we called as risk factors were those really old, frail patients who have COPD, who are on steroids, whatnot. Now, those are patients that also have a higher risk for transvenous devices. But that's something that the FDA kind of put a little tag on us, and, watch out for these patients. The more recaptures you do, the higher risk for perforation. So that's something that we've kept an eye on. Micro AV2 was kind of the next kind of fascinating iteration in my mind that leveraged the same microsystem, but was able to take the accelerometer that's inside the system and able to sense the atrial contraction. So it was able to sense the mechanical atrial contraction in a patient that has sinus rhythm. So a normal P wave that device is able to sense that a mechanical signal from the atrium and provide a synchronous ventricular pacing. So it would sense the P wave and deliver a synchronized ventricular beat, whereas the VR device was an asynchronous device. Again, a lot of clinical data on the AV device as well, whether it's from the early preclinical data, a lot of echo data that was looking at the A4, which is the mechanical atrial contraction, looking at the atrial signal, whether it's, I'm not an echocardiographer, but I understood the value of tissue Doppler and atrial Doppler signals and all that stuff during these AV studies. But what we saw in the pivotal trial for AV was that when we improved synchrony, which in this AV platform, you got more than 70% AV synchrony when we programmed these patients in this VDD mode, where they sense off of the mechanical atrial signal, we were able to actually improve the stroke volume quite a bit. And that was clinically relevant, that when these patients got an improved LVO TVTI and when they got a better stroke volume. So that was the next iteration. And this is quite how usually a micro goes. It's a kind of a tether-based system. You can see the tethers on ICE. Routinely, I don't use ICE for a micro implant. This was a post-extraction. Just like Rob does, we use ICE for our extraction. So it was a patient that we had to put a micro in after the extraction. So I had the luxury of having some ICE images in this patient. But you can see it's a short device and we're able to keep it off the valve. The most recent iteration is the Avia platform, which is a dual chamber. So you can have a right atrial device or a right ventricular device. It has its own delivery catheter, a sheath. It has its own programmer. So these are all parts of the system when we think about it. And what's the difference between the micro and the Avia system is because it's a dual chamber system, you have the capability of doing beat-to-beat synchrony between the two devices. So the atrial system can pace as well. So you have the capability of not only putting it in patients who have normal sinus node function, but also abnormal sinus node function. You can upgrade the system so you can actually put a single chamber and make it dual later on. And it has the capability of retrieval. Now, the microsystem, because it's time-based system, it was not designed to be retrieved. Now, many of us will retrieve a micro, device most of the time, but sometimes it's not quite easily retrievable, whereas the Avia platform was designed to be retrieved because it is a helix-based system. And that was the difference, is that it has this active fixation helix with a very high capacity battery. And what Rob showed in his case was an Avia device that was implanted. And that's because of the high capacity batteries where you get about 20, 25 years of battery. And it has this docking and retrieval mechanism that allows us to take this device out. But the difference is the device is a little bit longer than the Micra, so we have to actually implant this a little bit more distal in the RV to make sure that we stay away from the tricuspid valve. So can leadless pacemakers affect the tricuspid valve? There was a question in Q&A. If you put this device too close to the valve, yes, of course, it can affect the tricuspid valve. This is the atrial device. It's a much shorter device than the ventricular device, has what's called a dual helix mechanism, mainly to allow for a better, I would say, catch on the atrium, but also better stability. The other advantage of the AVEIR system is that it has this pre-mapping capability, which this helix, as well as the cathode in the VR device, we are able to map ahead of time. So, for example, if I extract a patient, there's usually some scar or some damage to the area where I just applied the laser or pulled, or like what Rob said, plucked out of. There's always some damage and some injury. So I can avoid those areas by pre-mapping and seeing what tissue I'm going after. So it allows for us to not have to recapture the device too many times. And we usually aim for kind of what we call the mid-septal area, we stay away from the septal leaflet and kind of implant it in that mid-septal area. And for the atrial device, we like to go into the base of the right atrial appendage. Obviously, we can go into other areas, but that's kind of our preferred location. And for the atrial device, we almost always use intracardiac echo. At least I use intracardiac echo in all of my cases. I know majority of the sites use it as well, because as everyone knows, the right atrial appendage is an extremely thin structure, and we like to use that. Now, I won't spend a lot of time on a case, but here is, we do it under, this is a DR implant that we're doing. You can see I'm doing an atrial device first in this case. And this was a patient that actually had a lead extracted and had intermittent AV block and sinus node dysfunction in the past, and had about 40% atrial pacing and about 30% ventricular pacing. And this is what I was talking about. We go into the appendage, we collect the injury. Here you can see we just screwed that lead in. We do it under ICE guidance. And once the lead is in, we'll kind of release it. We'll look at the injury. This is that injury that we see on the device. And that tells us that we have good signals. And here we released it. This is a tether-based release at this point. And then we come in, and you can do it any other way. I mean, you can do the ventricular device first or the atrial device first. I tend to use it depending on how I want to, what is needed, what kind of pacing requirement. And this was the case because I was doing an atrial device. I had ice in there. I was doing an extraction, so I had ice in there. So I was able to see the ventricular device as well. And you can see the pre-mapping. We're looking to make sure we're not going into an injured area. And we try to keep these devices as close to each other as possible, because we want the implant to talk to each other. So there's an implant-to-implant communication that we're looking for, and we want them to be oriented in a certain way that gives us the best optimized parameters. So this is data from the Leadless 2 study that was looked at the VR device. Again, very high implant success rate in these patients. Because of that pre-mapping, the requirement for repositioning is less, which means less risk for effusions, things like that. This is data from the DR, again showing not more than 95% AV synchrony. So in the Micra AV, you get about 70%, whereas you get pretty high amounts of AV synchrony with the DR device because it's an implant-to-implant communication. It's conductive communication, so a different parameter, very less amount of repositioning. Battery longevities, if you program them as single chamber devices, very high longevities that you're seeing. But as soon as you make it a DDD system where they have to talk to each other, it does suck down on the battery quite a bit. So we are looking at options of optimized pacing now, where we have other ways of doing that. Again, as I said, different ways of the implants talk to each other, implants talk to the programmer. So a lot of ways. As I said, the advantage being that you can do single chamber implants. And this was actually, to Rod's point, we're after years, back to doing AI pacing, where patients who don't need ventricular leads, we're not putting them anymore. And this was our data that we presented at APHRS with AIs, just atrial devices. And again, I think this is the way, like Rod said, this is the way we should look at. We only need to put in things that we need to use. And because of the upgradability feature, we were able to actually do AI-only pacing, again, showing great data with AI. And these patients really don't need upgrade that often. And if they do need it, we have the option of doing it. And as the other thing we talked about is retrievability. And this was a patient that we actually had to come and upgrade because of pacing cardiomyopathy. And because of the way the system is, it comes with the retrieval system. It's a tri-loop snare that allows us to retrieve it. You just counterclockwise rotate and remove the helix and take the device out in its entirety. And because of that, we don't have to put a lot of these devices in and leave them behind. There are other leadless systems that are coming. This is another one from Boston that it's a leadless system that talks to SICD. So a good option for patients who need ICD and pacing, or ICD and need anti-tachycardia pacing. This is data from the modular ATP trial that showed that you can minimize shocks. This is a system called a YCRT system, where you can do a small co-implant with a device that's already there, with this little device receiver electrode that you implant in the LV that allows for bi-V pacing. Again, not having to put a CS lead. Now, that's not truly completely leadless, right? But this is a system that's done retrograde. This courtesy to Vivek, this is one of the cases from the trial where you come retrograde and put this little implant into the lateral LV. And the data from this showed that these patients have significant improvement compared to CRT as well, and might be something to think about. And this was a total leadless system in a patient that had MICRA and a YCRT system, so no transvenous system in this patient. So potential for a total leadless system. Recently, we did early left bundle leadless device as well in patients that had heart failure. This is not in clinical trials yet or ID trials. This was an acute implant that was just performed in Prague. So that is where the future is where we are looking at single chamber or dual chamber conduction system pacing. And to me, leadless pacing is truly a paradigm shift. I do believe that it does allow our opportunity to expand this to a lot of patients, especially avoid injury to the tricuspid valve with the leads as we talked about today. And so a lot more to come from that standpoint. So thank you very much.
Thank you so much, Devi. That was an awesome talk on updates on leadless pacemaker. Any words, Rod and Bob? Any?
Well, I know our time is short, so I want to be clear and brief about some take-home points for the audience. Number one, as Paul said, think about it the other way around. What patients would you not extract? Because I think jailing should not be the default. And we'll leave it there. Jailing should not be the default. You have to give a good reason as to why to jail. And then obviously, like, EPs will have surgical backup for extractions and epicardial procedures. Think about having EP backup for those that are pacer dependent. So like the Firas case has shown that it's amazing to be able to move the lead over and get the valve in. But you have to think about having EP backup as well for those that are completely dependent, or we're going to have casualties, which is obviously not what we're looking for. We didn't even get time to talk about like conduction system pacing, but Schaller alluded to the fact that we're doing now intraseptal implants, and that actually has a possibility of pinning the septal leaflet. And that's why for electrophysiologists, there's techniques to go into the ventricle and pull back, which might mitigate that risk. But you're going to see a lot of conduction system pacing as well. But, and the last thing is that while leadless is clearly here, sometimes the leadless devices, and you're talking to an audience that loves ICE. I think we're outliers, Schaller, Devi, and myself with ICE. But sometimes you see that the button of that is actually interacting with the tricuspid valve. It's not as apical as you think it is in RAO. And actually that could create problems with implanting an evoke. So there's multiple case reports of saying we can do a leadless after an evoke. Can you do an evoke after a leadless? And that's an important question.
It is very important, Rod, because the cords, if you take any of those cords down to the apex when you implant or cause them to scar down, we've had cases where we've done a leadless, and unfortunately the tricuspid valve has become more tethered because of the pacemaker. And so we converted somebody who was repairable to somebody who needed a replacement. Not the end of the world, but it's just something to be cognizant that trying to just avoid all tricuspid valve interactions would be helpful. So I wish we had time to talk about conduction system pacing, but I think that'll probably have to be the next one, Nadira.
Yeah.
Because there's a lot to unpack there from what I mentioned about heart failure, the management of heart failure, and such, especially for these TR patients. But what I'm learning and what I'm thinking about more is that EP, our heart team is only growing. It used to be just a coronary interventionalist and a coronary surgeon as part of a syntax. Now it's, the TAVR team, and then it's the heart failure plus the TAVR team. Now it's heart failure plus TAVR plus EP, essentially the whole cardiology division. And so and the heart team is it's so important because these patients are so complex and they need
And
us.
imaging is for all of them.
Yes, I'm sorry. I didn't mean to overlook the imaging.
But it's for all the departments. So imaging is key.
Nadir, you want to wrap up, and then we'll probably be at the end here.
Well, I would like to say thank you so much for our KOLs, to our 3 KOLs, and for us as well, the structural side, and Paul as well for a wonderful 1-hour lecture. And we learned so much more to come in the EP world and also in TTVR and tricuspid CIED related TR. So thank you very much for everyone joining us.
Electrophysiologists are nice. Feel free to call us.
Thank you all. Thank you.
Thank you.
Thanks.
All right. Have a good night. Thank you.
Thank you, everyone. Bye.